I think as we're taking our seats, we might get started up again. Hey, Charles, can you just see if there's other folks outside getting started? All right, so it's my privilege to introduce our next panel, and in fact, I'm going to have them introduce themselves a little bit, and also speak some about why they're here today. And we have some cool slides that hopefully you guys will get to see some of the new work that we're doing in detecting appendix cancer. So I'll start with you, Milica.
Hello, my name is Milica Medved, and I'm a physicist, or more specifically MRI physicist, and my contribution here is in helping develop new ways of imaging that could be helpful in detection and characterization of lesions.
Hello, everyone. My name is Carla Horvath. I'm a radiologist. I'm an abdominal imager with interest in oncologic imaging. I am currently the interim chief of abdominal radiology here at University of Chicago, and I have been working closely with Dr. Turaga in order to work with detection of metastases and how can we do better, especially in peritoneal metastases in the setting of certain types of cancers. So we've been working together with him, with Milica, to try and develop new sequences, faster sequences in MRI, but also CT, ways of better characterizing and detecting the lesions. I'll talk a little bit more on how hard it is to see those lesions so you can have an idea, and some of you, I bet you do have that idea. We want to develop better ways of seeing them to spare your time to enjoy life and not spend that much time in the scanners with us.
Good morning, I'm Diana West, and my background is in chemistry and cancer biology. I work here at the University of Chicago as a staff scientist, and I'm here representing the laboratories of Dr. Chuan He and Dr. Mark Bissonette. And we've been collaborating with Dr. Turaga to learn a little bit more about the needs for a blood test for diagnosis and monitoring the disease for peritoneal cancer as well as colorectal and appendix cancer. So I'm looking forward to learning from you, and thank you for all of you who participate in research. I'm the one in the laboratory that works with the samples, so thank you so much.
Well, thank you all three of you. I think maybe we'll start with you, Carla. So Dr. Horvath is also, she's modest and she didn't mention this, but she's also the chief of our GI radiology and has been an incredible resource. But Dr. Horvath has some slides for you guys that maybe we can take a look at. And I don't know, Carla, if you want to come here or you want to speak from there.
Maybe I'll come there just to show what we're looking at. Maybe I don't need this. And her info. So I think some of you have gone through that, where you get a CT scan, and the radiologist is like, hi, I don't see any metastasis. Then Dr. Turaga goes in, opens, closes, there's a lot of metastasis. And that's what we want to avoid. We want to see if we can improve our CTs or MRs in order to detect those punctate things. There are metastases that he sees so much when he opens up a patient, and I still don't see it, regardless, even in retrospect. Sometimes we look at it together and like, I still don't see them. So this is an example of a case where we're trying to figure out if we can improve that metastatic detection. So in this case, this little dot here is actually a metastasis. But you can see how small it is, and how do I know that this dot here is not a metastasis and that other dot here is not a metastasis? What makes it different? And that's why in radiology we have a hard time detecting these little ones, because they look very much like vessels. They look very much like the adjacent tissues. The similarities and the enhancement patterns are too close for my eye to be able to recognize. So what we're doing now in MR especially is, with Milica's help, we're trying to improve the resolution in terms of space for MR. MRI can detect things, the signal, let's say that the color is different for certain tissues, but some of the very tiny lesions, the MRI still cannot see. It kind of blends in. And that's what we're trying to do. We're trying to first get a better resolution. That's called spatial resolution. Try to see if we can distinguish tiny things from the adjacent structures. And secondly, since the enhancement is so similar to the vessels, we're trying to find at which point I can differentiate these tumors for sure from the vessels. So we're trying to, and some of you who participate in those studies know, and I appreciate you being in the scanner for at least over an hour sometimes. Hold your breath, breathe. But that's the reason. We do several post-contrast scanning to try to see at which point my metastasis is going to enhance more than the vessels, that by doing some sort of analysis, computational calculations, that will pop up. and I'll be able to tell with more confidence, this is a metastasis. Dr. Turaga, do you think it's worth going in? Do you think your patient is going to benefit from it? Or at this point, let's just watch it. So that's our goal. That's our goal. It's try to characterize them better. At some point, we intend to discover the optimal time to scan, and then you're not going to have 300 breath holds. We're just going to do your scan at that one time that makes the detection better.
And I think, all of you have faced this problem is, either before surgery, when we're going in to do the surgery, we don't know actually how much cancer there is. We don't know what your PCI score is going to be. We don't know what we're going to find. And similarly, after surgery, when you're getting scans, or after chemotherapy, if you're getting scans, we don't actually know if there is cancer or not. So, Carla, can you also speak a little bit about what are the post-surgery sort of changes, and how do you kind of make these, does it cause a problem? Is it pretty straightforward?
Yeah, it is a little more problematic, let's put it this way. Once a surgeon goes in, your body is going to react to it. It doesn't matter how good the surgeon is. You're going to cut your body, it's going to cut the peritoneal lining, which is the area that I'm going to be looking at. Once you cut it, it's going to heal. But in order to heal, it gets a little thicker. You have inflammatory cells, so it starts to, what we call enhance. Basically, more blood goes into those areas. And that makes it difficult for me, because these are the subtle things that I'm going to be looking for. I look for the differences in that peritoneal lining. Is this a little thicker? Is it thicker because he went in and now it's healing? Is it thicker because I have new disease? So that's problematic once you have surgery. However, the only way we can resolve this at this point is to have serial images, because a metastasis will continue to grow and continue to enhance and get thicker. If it is just healing, most of the times it starts to wind down and starts to get better with progressive surgery. The only problem is we want to know now. We don't want to wait. But that's what, hopefully if we can calculate the perfect timing, maybe that will be mitigated as well. Another slight problem that happens once Dr. Turaga goes in, or any surgeon goes in, the body starts to produce a little bit more fluid in the peritoneum. And certain metastases, especially from mucinous appendiceal cancer, the mucin is this gelatin material that looks like fluid to me when I do my MRI exams. And when he asked me, is this metastasis or not, I'm like, it could be postoperative fluid, it could be metastasis, I am not sure. So these are, slight problems that we face once you get that follow-up imaging, and it's so hard for us not to be able to tell you for sure what's going on. Our goal is to tell you with, as much as confidence we can what you have and what you don't have. But at this point, these are things that we're trying to solve. I think with the blood, blood sampling combined with imaging, we may be able to resolve this a little bit better. But at this point, these are all our research projects, and we work very closely. He comes back to me like, this was metastasis, Carla.
Melissa, can you speak a little bit about this problem? How, in our work that we've done together, maybe can you speak a little bit about what are sort of things that patients can look to the horizon for?
So certainly, it's actually very interesting to speak about a study that we're currently doing, where we're trying to improve MRI imaging for better detection of metastases in the peritoneal lining, like the ones that Carla has shown. And as she said, the problem is really that they're tiny, and the smaller they are, the more difficult it is to image. And the thing with the MRI is that it's really very good at looking at bigger things, bigger metastases, bigger lesions, bigger organs, bigger everything. And just the regular clinical MRIs do not have the resolution we need. So part of our research project was to try and push the limits of technology to see how far we can go. And once we get to as far as we can get, is it enough? So we're using 3 Tesla scanners. That's the highest strength magnets that are used clinically today. We have very long scans, because the longer you scan for, the better resolution you can get with less noise. Noise obscures the outlines, the contrast of the lesions. So we're really trying to see what can we get out of the technology that we have today. Now, when you image a human, there's complications that arise just from people being, living humans who have to breathe, and their heart has to pulse, and their gut moves, and there's all kinds of motion, and that kind of limits in a different way what can be imaged. So we have all these breath holds, because that keeps the image still, and that lets us acquire more data and get to that higher resolution. And that's why all the breath holds, but some people can do it for 15 seconds, and some people can do it for 25 seconds, and it's actually quite rare for somebody to be able to do it for more than 20 seconds multiple times. So that's another limit we have to work with, and this is what we come up against when we design the protocols, because maybe for one person who can do 20 seconds 10 times, we could get a better image, but if we use the same protocol in somebody who can only do 15, then the image is actually going to look worse. Now, within these, let's say 15 seconds, we can get to a little under a millimeter size resolution, and right now we're actually conducting a study where we're imaging people prior to surgery and just try to be able to match what we see with, on the MRI with what we see in real life, like when Dr. Turaga comes in and looks at it, and then we match it up, and then we can say, okay, something this big can be seen, and something this small cannot be seen, and then that gives us kind of a standard for later looking at things. Now, as Carla was saying, we're also trying other things, like with using contrast. It's not really known at which point the contrast has the best effect. So we're imaging 3, 4, 5, 6 times along like this time after the injection. And we have a group that is doing computer analysis, matching up images from these different acquisitions to one another, tracking the contrast over time, looking at how it changes. Maybe it's not just a single time. One way of looking at it is just at a single time, what looks bright. The other way of looking at it is over time. Is something enhancing all the time, or did it enhance and now it's losing the intensity? Did it enhance the most at minute 3, or at minute 10, or at minute 20? This is all kind of a higher level analysis that people who are physicists do with the images, which cannot be done at the scanner at this moment, which is what the doctors get the images that are taken, they're sent to them, they look at them. But on the research side, we can keep the images for much longer than it takes for the diagnosis to be made, and we write code that does all kinds of processing, and then hopefully next year or 5 years from now, we can have the code put onto the scanner, and then the scanner might say, you know what, this is where you should look more carefully. So this is all what could come in the future, and hopefully we can make it happen faster.
And I think, just to kind of give you guys some perspective, in our clinical trial so far, of our 9 patients, Dr. Horvath and Dr. Odo, who's one of our other radiologists, we blinded one of them. We didn't tell them if there was cancer in that area or not, and we had them read it. Dr. Horvath had read them where we had compared everything, and Dr. Odo read it without, and 90% of the times he was able to find the cancer. And so that is higher than any other test that's been reported for peritoneal metastases. So we're waiting to see if we can validate this, and so it may be sooner than not that we have. So I think, if you don't mind, Diana, could you introduce yourself a little bit, and I'll kind of pull up some slides.
Sure. I'm Diana West, and I work in the laboratories of Professor Chuan He and Dr. Mark Bissonnette. And one thing we're excited about doing is developing a blood test for diagnosing peritoneal disease as well as tracking it post-surgery. It's part of a greater effort towards liquid biopsies. Oh, okay, here's some slides. Great. Just as a broader background, our bodies give us information in our blood, and this was appreciated in the mid to late 1990s. And since then, there's been considerable work to understand what are the different molecules in the blood that can give us information about disease, and that's our DNA, it's RNA in vesicles that come from the tumor cells themselves. They could be proteins, and they could be different chemical modifications on any of these particular molecules. And so the laboratory that I'm in focuses on studying epigenetic modifications. These are different ways that chemicals decorate DNA or RNA, and that we can detect these in the blood samples. And so one of the epigenetic modifications that we're focused on right now is called 5-hydroxymethylcytosine. And maybe I could just show really quickly. So there are many people throughout academia that are working on these research projects. So far, there are 2 liquid biopsies for blood tests that are available. One is for lung cancer patients to help doctors make decisions about treatment, and the other one is for colorectal cancer diagnosis from the blood test, and those 2 are FDA approved, but right now there's still a lot more work that has to be done to get something that's clinically useful and is going to be able to complement work. So these are our initial findings right now with peritoneal disease, in that we're able to use the 5-HMC mapping of the DNA from the blood to separate patients with the high-grade appendiceal cancer of origin, or the with colorectal cancer, or those without the peritoneal metastases. And so we think that this will help us to better diagnose the patients initially, and then we'd love to now apply this test to see if we can start to track this cancer and catch the relapse earlier after the surgery.
So I think thank you all. Many of you have probably given blood for this study, knowingly or unknowingly. And this is what
Hopefully
this
knowingly.
is what Enol, well, no, I didn't mean in that way. What I meant is you didn't know what the study was. Yeah, that's right. No, you gave consent, but maybe you didn't quite understand exactly what this is. But this is what it is really, if you see on this graph here, and there's small dots, and that's individuals, that's people like you. And and we can actually separate people who have cancer in the lining versus those that don't have cancer in the lining. And we're able to do that. We're able to separate appendix cancer and colon cancer as well so far. And I think this has been really exciting work that we've been fortunate to work with Diana, Dr. He's lab, and Bissonette's lab. And so this is really, really exciting work that we're able to do. We're all excited, but we still have to validate it. And so Enol is one of our research coordinators. Enol, if you want to just stand up and everyone can see. But Enol does approach many of you when you guys come to clinic. This is something we're trying to see if we can actually collect blood prospectively and find if we can detect this cancer early. And this is sometimes also called a liquid biopsy that you guys might have heard. So I think we have some time for some questions. I don't know if there's any questions from folks
that we can take for the panel.
I guess, do you see any relationship between appendiceal cancer and colon cancer? You know, if you have one, do you tend to get the other later or not?
I might take that. I think it's actually not as associated. In fact, we know that if you get appendix cancer, it's very rare to have colon cancer. And in fact, if you have something like PMP, when you do a colonoscopy, rarely will you find anything else in the colon. That's a good question.
I can talk about it. IGF-1 is a hormone, is that right? Is that detected through a blood test? And that's part of the DNA. As I understand, the low IGF-1 rating, you're more susceptible to lung cancer or skin cancer? Is that right?
Diana, I don't know if you want to take that or...
You know, what we're working right now on is being able to find DNA markers in the blood itself. So IGF-1 may be detected in some blood tests, but it's not our current research focus, but others may be working on it. That said, if there is a test that looks at IGF-1 and it turns out to be helpful for guiding patient and physician decisions, we would love to complement those tests with a DNA test to provide doctors with more information.
And then kind of a follow-up to that, you know, tests like, me, 23andMe, is that giving you any information, tests like that, or are there things that we should be checking within that?
Related to 23andMe, I think there are a number of groups that are researching ways to do whole genome sequencing from DNA that's found in the blood. 23andMe is a little bit different in that we usually give a saliva sample for those tests, and so they get our actual cells and get the DNA out of them and then sequence that. We're working with a little less information that's in the blood, just small fragments of DNA that are shed by the tumor cells themselves. So 23andMe gives you more information about ancestry and maybe different things that you can see in your DNA. And we're looking specifically at the tumor DNA with our tests and those others who are doing similar sequencing work. So it's similar, but I think it's a slightly different approach.
I think also as a follow-up, I would say that, you know, our take on the fidelity of 23andMe tests for clinical testing is very different. And so we don't necessarily use that data for anything. And I might have Dr. Polite also speak since you're here.
Yeah, no, so, I mean, the important distinction, of course, is between what we call germline and, you know, germline and tumor DNA. So most of what we care about really is tumor DNA at this point. Now, that's not completely true. In some of our cancers, we do care about the germline for treatment. The germline DNA, which is 23andMe, is more important to us for family. So if we find a genetic syndrome, that may have implications. Again, some of that stuff has treatment implications, but really the focus, what we really care about is what does the tumor's DNA look like? And the tumor's DNA is almost always, you know, has mutations that are very different than what we see in your normal cells, and that's sort of why they became tumors. So yeah, so 23andMe doesn't help us there. We will get germline. We'll do it sort of with a little bit, you know, sort of more fidelity testing. But again, everything everyone's talking about here is we care about what that tumor looks like.
And just to clarify, germline is sort of like what you get from your parents, like what's inherited, and somatic is otherwise. Yep.
What's the difference between, like, every 3 months having a CAT, like I have CAT scans instead of having MRIs?
It all depends. A CT scan is a very good exam to detect metastasis too. If you have large metastasis, a CT scan will detect. The MRI is a lengthier exam. It is as good as, it's a little more expensive. There's no radiation involved. So there are pluses and minuses of both. If you, let's say, I prefer a CT scan for what we call spatial resolution. Basically, I can see smaller things with better detail than a clinical MRI. So it's different, and this research MRI is a little bit more detailed. We don't get those tiny things on the clinical MRI. So a CT scan is perfectly fine for a follow-up. If there's a lesion or certain types of cancers that we detect better with MR, then we recommend and we talk about it. It's like, no, this patient may benefit from an MR. Or if I find something and I cannot resolve, because on CT scan sometimes soft tissue, meaning like the cell tissue, and fluid can look a little bit similar, complex fluid like blood. And sometimes I come together, I'm not sure if this is really blood, if it is, you know, complex tissue. So for those cases, I say, you know, I see this, let's get an MR to confirm. But a CAT scan is a perfect, suitable exam for continued follow-up. It's actually very good. It's less susceptible to motion. It's a not as long exam, not as expensive. It's very, actually, it's the most common exam done for follow-up and to try and detect metastasis in cancer. Of GI tract.
How concerned are you with the gadolinium used with the MRI? So I can take that because I actually did a lot of kind of literature search on that. And as things stand now, there is a couple of MRI contrasts. There's like many different kinds, but a couple of them seem to be very, very stable. There's another one that's being tested right now that also has very high stability. And this is important because the problem with the gadolinium is that with the gadolinium contrast is that the gadolinium ion itself is toxic. It's put into a larger molecule that is not toxic. it gets in the body, it gets excreted by the kidneys, and we don't worry about it once it's out of the body. Now, if it's unstable, then it might get left in the body in this free form. That's why we switched to, I think most hospitals now just use the stable compounds, and that has a very good safety profile. In fact, there is a disease called nephrogenic systemic fibrosis, which is induced by the unstable forms of gadolinium. Initially, people didn't know what exactly is correlated with it. Now they do. The contrasts we use now have no known cases of this disease, which just speaks to how stable they are. Now, all that being said, we're not going to use it willy-nilly. There's always a reason why it's used. But what we have now is many orders of magnitude more safe than what was very widely used just maybe 10 years ago. No, 15 years ago. Okay, so 15 years ago, everybody was using the one that was the least safe. And then the science has caught up, the studies were done, and now we know not to use that one. We use the ones that are much, much, much safer.
So when we go for an MRI, what should we be asking for? Which one?
So I don't want to give like this, yeah,
Do you want to answer that?
Well, because it may be commercial, and I'm not sure allowed to say, we use Dotarim, which is one of the commercially available ones that is very stable. Most places now are going to be using that. I wouldn't be too worried. And again, when she says that people used the unsafe one before, it's not because people are like, just electorally putting contrast that is not safe to you. We just did not know. And then once we found out that some patients were presenting with this disease, they start correlating, and that's when everyone, like, let's stop this gadolinium thing, let's see what's going on, let's rethink. So currently, the contrast that we use at University of Chicago and most places use are the very stable ones that the gadolinium molecule does not dissociate and stays in your body, gets excreted. There are a few, things that we're researching in terms of some of you may have read it, the gadolinium deposition in the brain that they find later in some patients. So they're still studying that, again, with the Dotarim, since it's a more recent contrast, we haven't studied much about or seen much gadolinium deposition from it. But we're always constantly monitoring those things. The FDA is also on top of us to make sure, or the drug companies to make sure it's all safe. But at this point, as Melita said, we're not going to scan anyone if there's not going to be a benefit. Number one, it's a lot of your time, it's a lot of your money, and being in the scanner is not without absolute risks. We try our best, make it as safe as possible, and it is safe. But we only use imaging if it's necessary. And again, I'm a radiologist. I love imaging, but I'm not going to recommend you getting exams that are not necessary for you.
Take the last question.
It's another type of contrast. That contrast is more specific for the liver system. It's also very safe. And that's excreted by the liver. So that's it's a gadolinium. It's very safe as well. It's very stable. But that contrast is mostly when we want to evaluate liver lesions specifically. Basically, that contrast gets absorbed by the liver cells, the hepatocytes, and that's why you have a later phase. But yeah, that's a very safe contrast as well, but it's more specific for the liver.
Great. Well, thank you all three. And stay tuned. Hopefully, we'll have more updates for you very soon. Thank you very much. So I'd like to invite our next panel. We're just running a little bit behind. So as they're walking up, I'll introduce all of them, and you'll have to fit the description to the person. So first we have, thank you. We have Dejan Micic. I've never figured it out. We've worked together for 2 years, and we've still, but Micic is his last name. He's a gastroenterologist, assistant professor of gastroenterology, interested in GI nutrition. And we work together very closely. Emily Fenton is our physician's assistant on our service. Many of you probably know Emily. Dr. Sandy Toon is a palliative care physician who has been with us, embedded in our clinic for the last year. We have Luz Chavez, who is our dietitian. Luz, you might want to raise your hand. I think it's hard to guess. Who works with our patients who are having both surgery and recovery afterwards. We have Sarah Makareg, who's a physical therapist, also focuses on pelvic floor, and Maria Alvarado, who's also a physical therapist with a focus on both exercise recovery before and after surgery and lymphedema. So I think that the title of this panel is Living Better with Appendix Cancer. So if you guys don't mind, I'll start it off with some questions to the panel, which they've prepared for. They have memorized answers. And then we'll open it up so you guys can ask questions, or obviously in between, if you have questions, you can also feel free to interrupt. So I think I'll start off with you, Dr. Micic. Can you speak a little bit about what are alterations of the gut that happen with patients who have surgeries such as right hemicolectomies, HIPEC? A lot of patients seem to have sort of these GI disturbances. Can you also speak specifically about things like probiotics? We hear about probiotics. Is this something we should use often? And then finally, can you also speak a little bit about when do we start thinking about things like TPN and nutrition that comes in the IV?
Perfect. So, like Dr. Traga said, I'm Dr. Micic, and I work with the nutrition support team here at University of Chicago. We work, there's 3 gastroenterologists that are part of the team. There's a number of dietitians, nurses, and pharmacists. And we really work with patients that generally have altered intestinal anatomy. When we look at the intestines, we think of it more than just one intestine. We think of the functions of the stomach, the small intestine, the first part of the small intestine, the last part of the small intestine, and the functions of the colon. They're all important in absorbing different things. Anything you see on a periodic table is absorbed very early on. Fats are absorbed later on in the small intestine. Bile acids are absorbed in the very end part of the small intestine. So how does the absorption of any of those factors have a role in what one person's able to absorb, what their nutrition is, and actually what their symptoms are also? Resections of the end part of the small intestine and the first part of the colon very commonly result in diarrhea. So how do we manage that after surgery? Those are the types of things that we see in cases that have had both cytoreduction and HIPEC. More importantly, there's also this idea of the small intestine has to churn and it has to function appropriately in order for it to absorb. So are there things that are easier to digest and break down? Are there certain proteins, less fats that are easier to break down in the intestines? What are the types of foods that people should be eating immediately after surgery? In the long term, we want to get people generally eating what they consider a regular diet beforehand, but early on, we focus a lot on starches, already pre-digested proteins in terms of maintaining their nutrition. I'll jump to the kind of third portion of things, which is just when the intestines for a time are not allowed to function, either due to an extended delay after surgery or just due to the amount of intestines that is really remaining after surgery. Some folks are on what's called parenteral nutrition or IV nutrition. This is something that's been around since the 1970s, and it's kind of one of the things that we're trying to look at a little bit more in terms of even what somebody's quality of life on IV nutrition, basically an IV that patients are setting up at home themselves every single night. We generally see people have really good outcomes with this. It doesn't come without its own risks in terms of infections of catheters, liver disease, so we're only going to use it in select cases. But it is one option when the intestines themselves won't allow for absorption. I guess so that's kind of the spectrum of what we'll see in patients with cytoreduction and HIPEC surgeries and altered anatomy. Just kind of as a common piece with the probiotics. Probiotics are obviously a very interesting piece where, like Dr. Petrotta was talking about earlier, bacteria are involved with the tumor microenvironment. So how do the bacteria affect the tumor? How do the bacteria also respond or are affected by the chemotherapies? It's an active area of research. Right now, obviously, we don't know exactly enough about what bacteria is in the tumor or what bacteria are interacting with the immune system. So we can't really just say, go pick up a store-bought version of a probiotic, which is usually like a lactobacillus, and knowingly say that that's going to benefit someone's tumor response. The cases where we use probiotics most often and where it has the best evidence is whenever people are exposed to antibiotics, it can reduce some of the adverse effects of antibiotics, particularly diarrhea. People can have an improvement in symptoms. Before surgery, we don't necessarily always recommend probiotics, although there are a few studies that show less complications when probiotics are taken before surgery. I think the bigger part before surgery, and this is the part I think Luz will be able to talk about, is the nutrition before surgery, really pushing nutrition before surgery. Think of it like a marathon. I mean, even carb loading before surgeries has been recommended in terms of reducing complications.
So I think this is a question and perfect segue for both you and Luz. You know, when someone's diagnosed with cancer, obviously instinctive response is let's get all the dirty stuff out of our system, let's get the McDonald's out, and let's get to the juicing and the, you know, the healthy, fresh stuff. But then we're looking at things like chemotherapy that Dr. Polite might do, or, you know, we're talking about surgery that Dr. Ang and I will do. You know, how should patients balance this sort of inherent desire to say, let's get oxidants, let's get berries, let's get juices, versus, you know, let's carb load, let's, you know, is that how do you think about those things?
So it's really individualized to the patient, and typically when I do visit with patients, I do kind of ask about lifestyle, what patients have access to, because even though fruits and veggies and antioxidants may be wonderful, sometimes it's not necessarily realistic, especially if they've been undergoing chemotherapy and maybe they just can't necessarily eat large enough meals in order to fit the fruits and the veggies. Sometimes we have to prioritize protein in those instances. There are situations where maybe funds can be an issue, and we kind of have to work with what the patient is able to kind of afford within their lifestyle to kind of customize our diet to make sure that we're incorporating some of these nutrients that we do need before surgery, but also just making sure that it's something that's feasible for them to do at home, and also feasible for them to prepare, because that's another aspect that has to be taken into consideration, is what are patients actually able to do with their energy level or with their resources at home, so that it's not adding to their stress, especially after having to undergo chemo. You know, this is a time they were supposed to be helping, not necessarily adding to the stress.
And then maybe can you speak a little bit, you know, about supplements? You know, we talk a lot about, you know, let's do the boost or the ensure, and that's a big thing we push. You know, how is this, you know, should everyone have like an individual dietary prescription? Is this something that we can just say, these are guidelines, all patients should do, things like that? What are sort of prescriptive homework that we can give all our patients?
So I think particularly before surgery, we really want people to be achieving really adequate calories. A lot of people will kind of cut down on the amount of calories, change their diet pretty drastically going into a surgery. I think the biggest missing piece is that we don't really want the calories to go down too much, and in particular the protein. In the setting of an inflammatory state, the body's going to burn down its muscles before it's going to burn down its fat. So really pushing the protein targets is really what we want. Kind of the simple calculation is we take somebody's weight, divide it by 2, that's their kilograms, multiply that by 1.5, that's how many grams of protein we want somebody to take in. We want somebody taking in usually 70 to 100 grams of protein a day, and a lot of that can be achieved through various energy or meal replacement drinks. Boost, Ensure, another one's called Inu, really just finding the ones at the store that are the most palatable and have the highest protein content, and taking 2 of those in for the week before surgery. Simple studies just like that have led to reductions in postoperative complications, infections, hospitalizations, how long someone's in the hospital after surgery. 2 cans of really something that's high protein is probably enough just even the week before.
Great. And I think on the topic of going through surgery, Maria, maybe can you speak a little bit about, you know, in terms of exercising, you know, all of us have different capacities. Some of us are marathon runners. Some of us are, you know, just it's hard enough for us to get up from the bed to the restroom. What are things that patients that have cancer, either that are undergoing therapy like chemotherapy or surgery, or that have been treated and are now living long-term, what are things that they should at least at a minimum do in preparation for either surgery or life?
Yes, I think exercise at all stages of the cancer treatment and recovery afterwards is very important. That whatever level you can push yourself to, it's important that you build the strength, have the muscle mass as much as possible, as well as the cardiovascular benefits of exercise. So there is a wide range in what people can tolerate, but certainly people with cancer and undergoing cancer treatment, it is safe to be pushing your body in terms of a cardiovascular exercise to levels that are moderate activity, which isn't just a light walk in your house, but maybe going out and walking at a slightly faster pace. that increases the heart rate a little bit at least to get the benefits of the cardiovascular exercise, improving the blood flow, circulation, and in the long run, maintaining and building that strength will only help in the recovery process.
So more like weights, or should it be more like running?
Yeah, I would say a little bit of both. That you need to have that muscle mass, but as they were talking about, that your muscles do start to break down in that inflammatory phase of cancer, that doing specific strength training, just basic exercises like squats and lunges, don't need to be doing intense weight training, but if you had been doing weight training previously, to continue with that, as long as your energy levels allow for it, and maybe even pushing the envelope a little bit. Cardiovascular exercise, I think kind of in two different categories, would be just as important, but at that moderate level, riding a bicycle, going for a walk, getting on the treadmill, those types of things.
Great. And Dr. Toon, obviously, as a palliative care physician, you're focused on making sure that patients have the best quality of life. As therapeutic physicians, we're always thinking about how do we get our patients to live the longest, but you're here to kind of help make sure that they also live well. And if they are unfortunate enough that, unfortunately they succumb to the disease, how do we kind of plan those transitions? So from your standpoint, what is advanced care planning? What are sort of hygiene things that all patients that are diagnosed with cancers, their family members, should certainly have a conscious decisions about? What are things that they should seek out? When should they meet a palliative care physician? Is it a bad word? Do we get scared about palliative care physicians? How should we think about this?
I'll actually address the second question you had there, Karen, first, which is talking about palliative care. When I meet people for the first time, they often get very nervous and they ask me, oh my gosh, are you the hospice doctor? I just wanted to clarify, hospice is something I'm trained to do, but it's not necessarily my focus. Palliative care is really the whole spectrum of care where I'm helping with symptoms and quality of life at the same time that people are undergoing treatments for whatever disease that they're looking for. And so I would say that palliative care in many ways becomes another layer of support where you'll have physicians like myself or nurses that are helping along with your primary medical team as well, which can be very helpful. That first part that you asked about advanced care planning, I actually think that every adult should start having conversations about who you want making decisions, God forbid, if you were unconscious or if you were in a terrible situation. It's helpful to start discussing these things with your family, trying to get a sense for kind of that emergency kind of contingency plan, I would say. I would say that it's never too early, really, to meet palliative care. I often meet people when they first been diagnosed and we're planning what's this path ahead of us. And all along the way, there's going to be these conversations about treatments that you're getting, but also about how you're feeling, about pain, nausea, constipation, difficulty breathing. And so I think palliative care can often be a really wonderful, ally during this battle that people are going through.
Can I get a show of hands? How many of you have advanced care plans, directives, advanced directives, living wills, post forms, anything like that filled out? Great. I think for those of you that have more questions, obviously we have more information and details as well. I think there's clearly initiatives like in Wisconsin where every healthy adult has kind of taken on this pledge of doing that for themselves. And then getting to the survivorship, this is a question both for you, Emily and Sarah, and then we'll kind of open this up to all of you for your questions. Emily, to you, when patients are coming back, every time they're getting a scan, it's like they're living month to month. They're kind of scared. There's obviously the financial toxicities of all of this stuff. There's all these other factors. What are things that you think of and clearly that patients should ask about when they're coming to see their physicians or treating team? And then Sarah, to you, maybe can you speak a little bit about things like sexual function, pelvic floor, all of these surgeries require a lot of work down in the pelvis area. How is that something that you evaluate, and how do you kind of do that? So maybe Emily, if you want to go first.
Sure. So as Dr. Traga mentioned, I'm the physician assistant on the team, and so I'm there in part in many of the aspects of care along clinic and in the hospital. So I'm really there and present during the entire kind of continuity of care there. And so what I think is important to think about with survivorship is how do we sort of go through the diagnosis of having cancer, and also how do we go back to living kind of our lives and go through our lives in a normal way. And so I think there are different ways that we can achieve that, and we're there to help you navigate that along the way and help you through this diagnosis, but also live your life the way that you want to. And so I think there are various ways that we want to be there for you and help connect you to resources that are available. And then there's also advice that I would pass on to you as far as ways that we can kind of help you navigate this. So I think one thing that's very important for patients is to stay connected, and that can look like relying on family members during the diagnosis of cancer. There are oftentimes ways that we have to rely on family members in ways that we didn't anticipate that we would have to. I think also it's important to look at support groups that can help us as well to navigate through this. And certainly there's the ACPMP, which we heard about earlier, as well as PMP pals and other support groups that can really help you connect with other patients that have the same diagnosis and better understand your disease. And I think that's another important part, is to know your disease and understand it. And we're certainly there to help you do that. And then there are also certainly resources out. The American Cancer Society has great resources. ACPMP, again, does have great resources so that you can better understand your disease. I think, again, knowledge is power, and we've heard that before today. And I think that's an important part of kind of getting through this journey and removing some of that anxiety that comes with the diagnosis. I think another important part of kind of navigating this is to be an advocate for yourself. And we want to help you connect to the resources that we have, but we need to know about those things from you. So it's important to come to clinic, express your concerns. There are several things that we see routinely with patients that come back after they've gone through surgery, they've gone through chemotherapy. There are certainly physical, emotional ramifications to that, as well as financial. And we certainly have those resources available. We have financial counseling and social work for financial issues. We have counselors that can talk to you about sort of the emotional ramifications, as well as certainly our surgical, our palliative care team as well, who can help us kind of guide you through that diagnosis as well. Certainly, one other aspect that can be difficult is talking to, perhaps if you have children, and being able to connect with your children about your diagnosis. And we also have child life counselors that can help you talk to kids about this diagnosis and help them understand where you're at with that. So in all those ways, we try to focus on making it easier for patients to go back to living their lives despite a major diagnosis like cancer.
Yeah, so, oh, that's loud, sorry. I'm the rowdy one of the group. I'm Sarah. I'm a pelvic floor physical therapist, but also orthopedic. And yes, we have muscles there, so we can rehab it. But alluding to what Dr. Tarago was talking about before is, yeah, absolutely. If you have any sort of abdominal or pelvic surgery, studies have shown, even with knee surgeries, that localized muscles in that area can sort of shut down after surgery for a period of time. So thinking your abdominal muscles are very well connected to your pelvic floor muscles. And with that pelvic shock, so to speak, you can have changes. And sometimes whether that's through urinary changes, and that can be a sign too, especially if you aren't quite back into your, back in the sack, so to speak. But if you're not yet up to your standard sexual function, change in your bowel or bladder symptoms can be a huge sign. So whether it's increase in urinary frequency or difficulty holding your urine or not getting there in time, and you're like, I had no problems with this beforehand, and now all of a sudden you're seeing these changes. Sometimes when you get back into your sexual function, either things don't feel good, or it's painful, or for men, having difficulties getting an erection. Sorry, I know I'm talking about sex, but you know, it's important for a lot of people's lives. And if you are noticing these changes and it's not right, this is me telling you to going back to what Emily said of advocating for yourself, of don't be afraid to say, hey, this isn't normal. What can I do about this? Because just because you had surgery doesn't mean that it's going to be like this forever. A lot of those nerves, again, supply that pelvic floor, and sometimes it just might need time to rest. Or you meet somebody who's crazy like me, and you get a pelvic floor physical therapist who can do a lot of that hands-on work to help with that scar, getting that scar moving, working on those abdominals, getting things to start working and strengthening and stretching again. Because a lot of the time when you've had all that surgery, you've gone through the disease process and treatment, you're not just like, oh, I feel super great. Your muscles are like tense because you've been anxious and scared, and those muscles, it's like a permanent sit-up, so to speak. So a lot of times you have a lot of muscle tightness, and that can therefore translate to your pelvic floor, which can lead to all of this sexual dysfunction as well. So, excuse me, things that would be helpful, it's sometimes hard to treat yourself, so to speak, on this. It's definitely something where you would need a pelvic floor physical therapist, but things to at least being aware and being in tune with your body, so then that way you can communicate with your partner. Above all, that's probably the number one thing, is having a good support system with your sexual partner of, hey, I'm having these problems, what can we do about it? And if it's from a libido aspect of things, or that and maybe it's hard to communicate with your partner, especially with all of the treatment that you've gone through. It's hard having those conversations. Sometimes it's your libido's not there. You're like, oh my God, I've been through so much. The last thing I want to do is like feel super sexy, or the willingness might be there, but your body doesn't necessarily perform what your mind is wanting to, and that is very common. So that's where people like sex therapists, who are trained psychologists and psychiatrists, who they're not going to teach you how to have sex, but they're going to help you learn to communicate better with your partner, and maybe find different ways of having intimacy as your body is healing. And you might go back to where your prior function is, or things might change, which could be exciting. So that's an option. If you're definitely having pain or difficulty with arousal, that's where physical therapy can help, because it's a muscular thing. It's working on that muscle strength, that muscle pump, so to speak, is what helps our sexual function. And that's right up PT's alley, strengthening and stretching and working on breathing. So a lot of times with some of our patients' rehab, we give them diaphragmatic breathing, which we're not doing that just for sex, but it does a lot of other great things too. But doing diaphragmatic breathing, that lovely belly breathing, helps relate to your pelvic floor, and it gets mobility in a tissue. And something that I explain a lot to patients is, sometimes if somebody has incontinence, you'll hear a doctor say, oh, just do Kegels, which is fine, but also could lead to other problems too. Because thinking of like your bicep, for example, if you were tight all the time and I told you to do more bicep curls, this isn't very helpful. Like, I need you to lengthen your muscle in order to strengthen it. And a lot of times that's where that diaphragmatic breathing comes in, because it helps with gaining that mobility back in those tissues, instead of just focusing on strengthening all the time. And like I said, a lot of times people are so tight because of all the stress and anxiety that's been going into all the treatment. So that's where helping with the relaxation component comes into, and that's where pelvic floor PT can help. Sorry for rambling.
No, I learned a lot. I always say Kegel exercises every time.
We're teaching him.
All right, so I think we have some time for questions. I know we're going to be a little bit late, but if you guys are okay, I think this is a great panel. If you guys have questions, please. I don't. Yeah, just have a microphone.
Well, also thank you, Justin. He's a great member of the team. He's been awesome. I have two questions. One is, does anybody have any advice other than gabapentin in regards to neuropathy after chemo? And the second question, is this being videotaped so that our family members could watch it?
So I'll answer the second one. Yes, it is being videotaped. And the first one, I might ask Dr. Polite.
So, you guys don't hear me. So when we think about neuropathy, specifically the neuropathy that's caused by the oxaliplatin, there are two questions, I want to know. Is it painful neuropathy? So is that burning pain, or is it just, I'm numb? The numbness, unfortunately, we don't have any great drugs that help the numbness. A lot of people prescribe Neurontin and Lyrica. We've actually studied it in oxalic platinum neuropathy, and it doesn't work. So it tends to give people a lot of side effects and not a lot of benefit. People have played around with capsaicin and other type of things, and lidocaine. Again, that helps you fine. For the painful neuropathy, however, we do actually have studies. And the drug that we use is a drug called Cymbalta. We started at kind of a lower dose of 30 milligrams, and we'll go up to about 60 milligrams, and it works wonderfully for the painful neuropathy. And again, we have actually good, what we call level 1, meaning clinical trial data that supports that. So I always get frustrated when a lot of people on Neurontin and Lyrica, similar to Kegel exercise, that's what everyone reaches, when they talk about neuropathy. It doesn't work for oxalic platinum neuropathy, I'll tell you right now. And so I'm a strong fan of the Cymbalta. It's just a numbness. Unfortunately, it's one of those things that will get better over time, and we just sort of have to wait. That's where I think occupational therapy, if people are having issues doing things, can help. So how do I do the things while I wait for this to recover that I want to do? That's where occupational therapy can be very, very helpful and help people figure that stuff out.
Questions? Boy, I thought there was going to be a lot of
I'll ask a question. Well, so I would like you guys to speak a little bit more about the managing diarrhea. I'm sure my husband would be thrilled that I'll let you all know. He's had, after 3 HIPECs, sort of chronic, and he was very heavily reliant on Imodium. And I had told him, and his doctors knew, and they were okay with it, but it's sort of made us, his wife, kind of uncomfortable. And over the years, over 10 years, he has finally weaned himself off of it. And I'm really proud of him for doing that. But I mean, and he's admitted, he's like, I think I was kind of emotionally and mentally reliant on it because I was afraid of being in a meeting or on a plane and having this, bad situation. So I think maybe people are afraid to ask, but I know many of you are dealing with that. So if you could talk a little bit more about managing diarrhea.
From the diarrhea standpoint, that's really where it matters kind of what is the intestinal anatomy, how are the intestines functioning, and what are the things that we can separately do for diarrhea. So I always kind of think of it as like a multimodal approach. The first thing is there anything in our diet that routinely causes diarrhea? Sure, lactose is a sugar that lives in dairy products, and then also any kind of artificial sugars or sweeteners. They taste sweet, they don't get absorbed in our intestines. We might as well just be taking Miralax, which is a laxative. It goes to the colon, causes diarrhea. The second thing is in the setting of intestinal surgeries, one of the most common places that's actually removed is a very end part of the small intestine that absorbs bile. I always describe bile as like a dial soap. It breaks the fat in our kitchen pans. It breaks down the fat that we eat. Bile is supposed to be reabsorbed in our intestines. If it goes to the colon, it's like you're adding soap to the colon. So bile binders bind up bile and get rid of that irritant piece to the colon lining. Those are taken either at nighttime, sometimes several times a day. That's actually probably a better way of managing than just Imodium. The third thing is then the food has to travel through the 12 to 20 feet of small intestine before it gets to the colon. It needs to be absorbed well. What foods are better absorbed? Starches and carbohydrates. And that's where also taking Imodium and things like that, timing it with meals, before meals, to slow down the intestinal transit, allow for more absorption before we get to the colon. And then the last part then is also we actually go to our pelvic floor physical therapist for being able to hold the stool in too. So incontinence is a very common problem with diarrhea. Is there another part of the rectal muscles and their functioning for control of stool patterns?
And then perhaps also, I think making sure that we see someone like him, just to make sure there's tests and other things.
I think I'm really pleased to see that you have the support system because I think a lot of other centers, even some of the higher line centers, are not providing that kind of support. I'd be interested to talk to some of you afterwards to see if you're, feel like you're supported with a lot of these issues. Because a lot of people travel and they go home and their doctors at home just don't understand. So I think it's fantastic you have this team and that you all should, even if you travel, reach out to them. We've got email, we've got phones, you can get the support even if you're a distance away. It's a fantastic team.
Sorry to show my ignorance. What is a bile binder? Is it a
So it's a prescription. It's a prescription. It's either a pill form or a powder form. It actually used to be used to bind up bile, which means that cholesterol isn't absorbed. So the main side effect is your cholesterol is a little bit lower. So we used to use it as a cholesterol lowering agent, but we have much better cholesterol lowering agents now. So it kind of fell out of the popular realm of prescriptions. Within GI, we use it all the time. Cholestyramine, cholesalverin. Yeah.
Is that something
Yeah, GP or any GI. Yeah. So.
This is a disconnect. You have to know about it to ask about it at home. That's the problem we have with this patient population. So I encourage you all, if you're a senior, look at this team that's here for you. Reach out to them. You don't have to be here to, I'm assuming, to get in touch and ask these questions. So.
Did I understand you to say that you should eat more carbohydrates? I don't know if I caught that right.
So kind of before surgery, yeah. So kind of there is some work on kind of carb loading and everything before surgery. So kind of what I focused on earlier was a little bit more before surgery, getting ready for surgery, preventing complications. After surgery, really, I think that's also a pretty common question. What should we be eating after surgery? I take a lot of that literature from the colon cancer literature and really kind of just pointing towards a Mediterranean diet that is naturally a little bit lower in carbohydrates and focuses more on the anti-inflammatory fats. So that's something that I kind of push more towards for after surgery.
Any more questions?
I was just going to say, Emily, you got that bill for me from the doctor, that colas, whatever, and that is unbelievable how much it helps. It really is fantastic.
I'm glad it helped.
I have a question. So for patients who have family members who are struggling, what kind of resources would you guys recommend for their family members who are struggling with the diagnosis?
So what I would say is that it can be very multifactorial about what's going on. There can be a lot of stressors, as Emily alluded to earlier. One of the things that can be helpful is for patients to bring family members in to the appointment so they can have these conversations in front of our care team, and we can kind of help facilitate some more of these kind of explorations of some of the stress and the anxiety that's there. Otherwise, there are options here at our medical center as well, where we have psychologists who are oncology specifically trained, who can help with some of more like group type therapy as well. And then otherwise, support groups can also be a very important way, I think, for people to get support. Mm-hmm.
All right, well, if there's no more questions, I wanted to thank all of you on the panel, and thank you again for doing what you guys do, so thank you. And then we saved the best for last. We wanted to invite Jennifer Bernal. She's one of our patients who's been gracious enough to volunteer her time. Her family is the most lovely family that I've known now for quite some time, and they always come and show up to support these events. And right after Jennifer's talk, we'll have lunch. So stay tuned, focus.
Hello, I know I'm standing between you and lunch. So, I'll make sure.
I think it's that one over here.
Or which one? Oh, I see.
It's like flipped over.
All right. So thank you guys. I think, first, thank you, Dr. Taraga, to you and your team. I see a lot of wonderful faces that, a year ago, 2 years ago, were foreign to me, but now I look at your faces. You guys are as much part of my family or part of my family as well as my family's family, right? But as I was thinking about my story, I know my story isn't that much more different than a lot of people that are in this room. There are certain unique factors that we go through as patients, things that we experience with our family, with our caregivers, with different providers that have made us into the cancer patients and survivors that we are today. And so hopefully you guys can take away a little bit from my story. I think I came from a place where from one end of the spectrum, I was a patient that really kind of went from referral to referral. I didn't know what I was doing. I didn't have the information I needed. And to be honest with you, I think my journey started when I was in my 30s, where you kind of have this mentality that you're healthy, you have a long life to live, everything will be fine. To the other end of the spectrum, to fully realize how important your resources and the care and the care and providers that you incorporate into this journey can really take you where, as far as you need to be and where you need to be. So for me, I got married in 2012 to my wonderful husband, who's up here. We were together for a very long time before we got married. We wanted to make sure that we had the right things in place, careers, goals, homes, one home. I don't have many homes, one home. But just put everything in place to have a successful life together and a loving life together. So once we got married, we tried to have children, right? And so I think I'm not alone in saying that a lot of women experience fertility issues and maybe they don't get their families off, right from the start. And that was the case for us. So in 2015, we sought out the assistance of Dr. Feinberg, who's now with Northwestern, just trying to figure out, hey, what's going on? Let's see how she can help. So in 2015, we did some testing. From her perspective and from her team's perspective, my uterus was inverse. So it was a little bit heavy, right? So we did a hysteroscopy, and after that surgery, I felt a little bit of pressure. I felt like I had to go to the bathroom all the time. There were symptoms there that I didn't have before. I was like, this feels off. And so I didn't really voice my concerns. I think I was so focused on the fertility journey to, all right, this is step one. Step two is we're going to do the IUI, and then I'm going to get pregnant. We're going to start a family, right? So shortly thereafter, I did an IUI. And so the IUI didn't take. And I went in for the next scan to figure out the next step and the timing of when everything was going to take place, the next IUI or IVF, whatever it was. And so I was laying on the table, and the tech, I noticed she took that scanner, and she went from my lower abdominal area, and then she started going higher and higher and higher, in different places along my abdomen. And at that point, I was like, something's going on. And she was very quiet, didn't say anything, but at that point, I knew. So from that point on, Dr. Feinberg, she was very helpful. Like I said, I was in my 30s, figured I was healthy. I didn't even have a primary care physician. I didn't go in for my annual physicals or anything like that. So she took me under her wing, and she sent me over to North Shore. And North Shore, it took them a few weeks to figure out what was going on. We did a biopsy, we did the blood draw. And we, at first, like many probably in this room, were not misdiagnosed, but what they thought was ovarian cancer, right? So afterwards, they finally figured out, okay, we're dealing with appendix cancer. This is a unique situation. We need to get you to the right referral. So when you're first diagnosed, I think there's this instant fear, this instant of, you know what, I got to do things fast. I don't have time. I need to make decisions. And so from that point, we were referred over to Loyola. And with that appointment, we learned a little bit along the way, right? But what I didn't do right as a patient in that moment is I didn't take the time to educate myself. What I did was I just jumped from word to word to word and make decisions on, based on what people were telling me. And I think had I had taken the time, looked at resources, tried to find others as a point of reference to understand what this journey would entail, I probably would have made different decisions. So in saying that, in 2015, in October, that's when I had my first debulking surgery. And I had woken up, and I should say, before they prep you, you got to sign off. We're probably going to remove your gallbladder, your appendix, your spleen, all these things could be diseased, and you could lose them. Okay, let's sign, let's do it. And I just took the soonest appointment available. After my surgery, I woke up, and I had a breathing tube. I had a tube, tubes coming in and out. I couldn't lift up my body. I remember being handcuffed to the bed. And that I was not expecting at all. That was a shock. And so during this process, I don't think, like I said, I didn't take the time to realize what I was in for and what I should have mentally and emotionally prepared for too. So after the surgery went well. They were able to get 15 pounds of tumor, you know, a mentum, gallbladder, appendix, every, you know, typical organs, right? And then I had an ostomy. And so I struggled with the ostomy. I think ostomies are, the first time you experience them, it's an out-of-body experience, and it's a struggle to be able to accept. I think that was another area where education would have helped me out a lot too, because my recovery after my first surgery, it was a 6-month period where I couldn't walk for weeks. I was always fatigued, I was always sleeping. And I think if I had the information, or if I knew what I needed to do, I think that recovery would have been a lot shorter and a lot more successful. So at that point, with Loyola, I finally recovered. I got the ostomy reversed, and I was on my way. But then a year and a half later, we had a reoccurrence. And the reoccurrence was in my left lung, and I had to get referred out to UPMC. UPMC, great facility, great doctors as well. Everybody in this field is really talented. And they were able to do debulking on the left lung, and they were able to get most of it out. There was a small piece, but it was stable, right? At that point, that surgery was actually in October to December 2017 was that recovery. And so during that period, my primary oncologist, surgical oncologist, was leaving Loyola. And it gave us the opportunity to kind of see what's out there. Fortunately for me, I came across ACPMP. Finally, while I was recovering, I was like, you know what, I really need to figure out why I'm not finding other patients. I think every time I came across somebody, they're like, I've never heard of that. I didn't even know you could have cancer from the appendix. Well, if you take the appendix out, doesn't that mean you're cured? No, not exactly, right? Yeah. So, but I came across ACPMP, and that opened, I mean, it was just like a door, like a gate of light came into my life, because I was able to get the resources I needed. I came across other cancer patients. The first cancer patient that I came across was Carol Cox. She, as you mentioned, she's the one who has pulled together Carol's Flowers and donated $40,000 to $50,000 to ACPMP. And when I went to her first garage, we were talking for at least an hour while she was having this event, and she was, you know, I mean, she was doing so much good, but I think we were so excited to be able to meet each other and talk to each other face to face, and it literally filled my heart with joy to be able to relate to somebody, to exchange stories, to understand what they went through and how we could help each other. So like for her, I think you know, part of her journey was she was gonna have a pending ostomy, you know, as part of her surgery. And I was able to help her. I was able to tell her what to expect, what to look out for, how to make this experience better, you know? It definitely wasn't a journey that we wanted to be able to connect on as human beings, but it's a journey that we carried each other through. And I mean, Carol and her family, if it wasn't for Carol, I never would have found Dr. Taraga. Because it was through her words and her family's words that I was like, you know what, I need to find a provider. I need to find a surgical oncologist that I can relate to, that I feel confident in putting together this care plan together. Because the weight of this cancer is so heavy. It takes away so much that you've got to figure out ways to bring it back into your life, right? We know the fatigue, we know the pain, we know the struggle. We know, I mean, for me and my husband, you know, unfortunately with the first surgery, they had to remove my uterus and my ovaries. You know, there was no opportunity. I felt like I had died that day. You know, I felt like genetically, I wasn't able to pull a family together. I wasn't able to give him, or what we dreamed about, right? When you have a team behind you, from a medical perspective that focuses on your health, for you to feel confident in how they are putting your care together, it allows you to focus on other areas of your life, right? And not only that, but it's not only what he does and the surgical team does, but it's the team that was sitting up here just moments ago. Whether it's physical therapy, whether it's nutrition, whether it's psychology, you know, it's a lifelong journey that we have to carry, and we have to be able to manage from an emotional and mental standpoint. And so those pieces felt like home. Like it allowed me, while you work on giving me longevity and giving me more days and more years in my life, that aspect gives me more life to live. So it was so important, because I remember the first day that I actually came to University of Chicago for the interview process, if you will. And these rooms aren't that huge, right? But he filled every corner of the room with the entire team that was sitting up here, and we were like, whoa, what's going on here? Like, I wasn't sure. And so, you know, person by person, we went through how they played an important integral part in what we were about to go through with them. And also, he took the opportunity to take me from point A, because even though I had surgeries already, because at that point, I had 3 surgeries, right? And this was gonna be my 4th major surgery, but I realized sitting in that room that I didn't know nearly what I should have known at that point, you know? And so he busted out the whiteboard and showed me, you know, everything from high grade to low grade to different types of cancers and how they're treated, whether you can use chemo, it's HIPEC, et cetera. And so we left there instantly, and we knew this was where we needed to be. And so I'm thankful for ACPMP, I'm thankful for Carol, I'm thankful for University of Chicago and Dr. Turaga and the team. Like I said, you guys are a huge part of our family and being able to give us life back. And I think that's what it's all about, is we, you know, this struggle is not easy by any means. Like I said, it takes away so much, right? Day to day, year to year. If anything, I think the cancer has given us perspective. You understand what's important, what's not important. You understand what you value in life and what you don't value in life. And I think when I came to University of Chicago, that's when I understood what this journey was supposed to look and feel like, you know? And being able to reach out to other cancer patients, having that community to bounce ideas off of, or I remember there was a point where I was losing my hair, and I went to the oncologist that I was working with at the time, and I said, is this normal? And he goes, no. He's like, you're not doing chemo. You know, I was like, well, my hair's coming out in clumps, like, what's going on? And there was really no answer. But when I found the Facebook group and the PMP support group, like, there were so many people, there were so many posts, there was so much information of different topics that we could all relate to and understand what we go through as cancer patients. And so I think that's where, when I had that information and I had that support, it made this journey that much, not that it's easy, but a little easier, you know? So, and I didn't even share the rest of my photos, sorry. I got a little emotional. But in the care team also within the hospital, my husband's family, they're probably about 60 to 70 plus with aunts, uncles, and cousins. There were days where there were probably 20 people. And the team in the hospital room just happily and openly accommodated all of us, tried to get chairs in there, because I think they know how important this support is. And you know, it's hard if you're sitting in a hospital room by yourself. You know, those thoughts take over, the realization of the pain that you're in, but when you have these smiling faces around you, that's medicine. That's medicine, you know? So I'm very thankful for my family and everything that they've done, and how University of Chicago has also treated my family. Because you're not only treating the patient, you're treating the spouses, you're treating the mothers, the fathers, the children. You know, they're going through this as much as you are as a cancer patient. And while you're going through this, and you're going through this battle, they're carrying up the rest, they're holding up the rest of the world for you. My husband holds my entire world together. And I know he didn't choose this life, he chose me. Sorry. He chose me, and I think there's an aspect of this where, as cancer patients, you feel guilty. You feel guilty of bringing this onto your family. But they are so strong and they're so resilient, and you know, and I'm just thankful for the resources that you guys have to help hold us together. It's so important. What's important to me, I know is important to Dr. Taraga. It's not just treating the cancer, it's not just treating the tumors. It's treating the person, and it's treating the family. So with that, I say a big thank you to you and your family, and a big thank you to my family and my husband. So thank you for your time, and thank you for doing this. This is really important.
Well, thanks, Jennifer. That was, it's moving, very, very. But I think with that note, I think we'll conclude our session for today. I wanted to thank Pujita one more time, and Justin, both of you. Thank you very much for everything you guys did. And for ACPMP and everyone else that helped us put this together. There's lunch over here. There are marked boxes for those of you that have dietary restrictions. So there's vegan, gluten-free, and other kinds of things, heavy carb. And thank you again. Hopefully we'll see all of you again next year or sooner. Okay, thanks.